I was actually in the NICU as part of my training, and there was a patient there that had severe brain injury, was on a ventilator, had a feeding tube, and I recall a meeting that the neonatologist had with the mom, basically telling her, your daughter's going to be dependent on this technology, and she's likely not going to survive beyond X number of years. So that very first tour I had of Bethany Children's Health Center, I was walking down the hallway, and I was introduced to a girl that was walking accompanied by a nurse, and it was that girl.
Wow.
And at that point, it was clear to me that that is exactly where I needed to be.
Thank you, Dr. Brannan, for sitting down with us today, all the way from OKC. Yes. How's the weather here?
Here, it is cooler.
Cooler.
Than Oklahoma City, yeah.
At 85 degrees, we're cooler.
Oh, absolutely. When I left on Wednesday, it was 102.
Oh, my goodness.
Yeah, so it's
okay.
been...
Well, welcome to our cool 85-degree California. That's what we're known for.
Yes.
Thank you for sitting down with us today. You know, you've been... you've seen so much at Bethany Children's Hospital. Your career there has spanned about 3 decades, which is awesome. So a lot of the questions that I have is I'm just genuinely so interested in how you've seen healthcare change. And, I guess we can start there. What do you think, since you started a career, you started as a clinician. First, what made you make the jump into no longer practicing into more leadership, administrative side of things?
Okay. Well, I think while I was in private practice, I did have a number of kids with complex medical needs that somehow found me in my practice, and then kind of was eventually approached by someone to come out and become the medical director of Bethany Children's Health Center, which at the time was the Children's Center. So we've gone through some iterations of naming. And the curious thing was that, kind of taking a step back about 4 years prior to that, I was actually in the NICU as part of my training. And there was a patient there that had severe brain injury, was on a ventilator, had a feeding tube. And I recall a meeting that the neonatologist had with the mom, basically telling her, your daughter's going to be dependent on this technology, and she's likely not going to survive beyond X number of years. So that very first tour I had of Bethany Children's Health Center, I was walking down the hallway, and I was introduced to a girl that was walking accompanied by a nurse, and it was that girl.
Wow. And
at that point, it was clear to me that that is exactly where I needed to be. And I think that I would look at that as a calling, because we have a culture, I think, at Bethany Children's Health Center where we all really, truly do feel called. It's something that we would give our life for, and we commit ourselves to improving the quality of life, and more importantly, the ability of not only the child, but the parent and family to be able to have a meaningful life, meaningful existence. So that was kind of where it all began. And, gradually as time went on, we ended up having new service lines, began complementing our services with radiology and lab, had our first EHR, and then having more and more, or I would say a higher complexity of patients, going from maybe 10 or 15 kids that are ventilator dependent to 25, 30, 35 kids, clearly requires a higher level of care in our facility, all of which really demanded for the need for quality documentation, the ability to be able to provide the resources where not only our providers, but also the nurses and physical and occupational therapists, our dietitians and social workers, all of the other disciplines to be able to have this single source of truth that they could all work from. And so throughout that period of time, it has been, I would say, critical for us to have actionable information, to have reliable information, so that we can, in fact, know what it is our trajectory is with each of these kids. And the ultimate, I think, measure of success is seeing the child discharged.
Yeah.
And in our facility, we have discharge parades. So as the kid is exiting the facility, all of the staff will come out of the units and will greet the family, as they go out the door with fanfare. And so it's just an incredible place to work. And I'm blessed to be able to be there.
Certainly. I always hear that people who work with kids, the families will always say that their kids receive such incredible care, even compared to the care that like adults receive, just the attention and the compassion that providers have to give those kids, even if it's a short stint in the hospital. It bears so much weight for that child and for the family. So I can totally understand why that would be such a meaningful vocation for all of you. In your time at Bethany, you've seen a lot of change. You've probably seen a lot of things that have progressed quite a bit, mortality rates dropping meaningfully, but you've probably also seen some pretty interesting failures, things that you guys try, doesn't work out. Talk to me a little bit about some of those initiatives that, you all might have been really excited about and then sort of fell flat a little bit and makes you a little bit wary about things in the future.
Yeah. Well, I think our first foray into our EHR was around the time that all of the other facilities were going down that pathway of implementing EHRs with the promise of being more interoperable, being able to provide better quality care. But I think one of the major focuses at that point was discrete data. If it can't be measured, it can't be reported against, we can't, extract the data, we can't use it. And that ultimately led to poor user satisfaction. Really contributed, I would say, a lot to burnout, alert fatigue. So the lessons learned for us were no different than any other enterprise that had implemented an EHR. And of course, that lesson with our next EHR was that, whatever the mode, whatever the format of the data, that the provider wants to give is what we need to support. It ultimately needs to be an ability of the EHR product to consume the data and then to allow us to be able to not only digest it, but utilize it on the back end. And of course, with natural language processing and the advent of AI, it certainly makes that task much easier. That we're no longer structuring our data around some need that a clinical informaticist needs, but we're structuring it around the end user and what makes the most sense. Because now we're not restricted by whether it's a narrative or whether it's a discrete data element.
Right. You just touched on how many challenges hospitals and health administrators deal with. I just realized, because it's not just there is clinical issues and the issue of how do you deliver the absolute best quality of care to patients, but then there's also the issue of we have a physician shortage and you want to create like the absolute best environment for doctors to attract the best doctors and keep them.
Right.
And that is, a very, very important problem, between the two things as well. How do you prioritize, you have hundreds of different doctors that all want different things on top of thousands, millions of patients that want different things. How do you prioritize all of these different needs?
Well, I think as long as your focus is the patient and what the patient needs, you can never go wrong with that. And again, I'll go back to the culture. If you have a culture that exists within the enterprise that has that same objective, what is best for the patient, then you have, I think, an anchor. Beyond that, it really ends up being looking at the workflows of the different disciplines. Nursing, by far, is the most efficient, most important role within the hospital. Clinicians, we don't do a bunch in a hospital. It really comes down to the nursing and the nursing staff. So I think by and large, that kind of alignment of the patient needs and the nursing documentation is by and far the most critical. Beyond that point, it really ends up being, okay, how do we complement that with the additional information that's necessary? Lab, RAD, the encounters that the consultant has at the bedside with the patient. All of that needs to be able to draw on the document that the nurse has, the lab report, the radiology report, as opposed to the provider regurgitating all of that information all over again. So I think from the standpoint of prioritizing what it is that needs to be done to provide the most excellent care, ultimately is patient first, understanding what the patient's needs are. Then it's easier to kind of layer on top of that what it is that you need to build out from the standpoint of the information. Beyond that, so you've got your information, you have your data, and then you've got to be able to use that information in such a way that actually you can have knowledge. So it's not just one way or one thing to know what the blood pressure was and what the creatinine level was, but how do you take that information and then create knowledge from that? And then ultimately, how does that information get to be able to improve the quality of care for the patient? So, I would say that it isn't as difficult as one would think, as long as you always have that patient in the center.
So what are some initiatives that you've really championed over the past couple of decades that has trickled down in improving quality of care for patients?
I would say the absolute most important has been the transition from discrete to narrative, is not having those guardrails so structured as to not permitting the end user to be able to engage with the EHR in a way that allows them to be able to meet the needs of the patient. So I would say that has probably been paramount. Beyond that, it's being able to, I would say, and part of this comes out to maybe looking more external, outside of our own facility, at our clinic or the partnerships that we have with consultants and other clinics in the community, is to be able to understand what it is that they need in the form of, let's say, as a patient is discharged, how do we communicate the goals and objectives to that therapist in the community? How do we communicate some of the requirements or needs that the kid may have after they're discharged to their primary care provider? All of that comes down to interoperability, health information exchange. So second would be is the ability to embrace interoperability, be able to share information, exchange information, and to be able to do that in such a way that it is meaningful and it's actionable, that someone on the receiving end can actually take that information and make sense of it, and at the same time be able to use it to, again, help the patient achieve their maximum objective without having the ability, without having interoperability. Caring for a child with complex medical needs becomes incredibly difficult, and it does put the child's life in peril. So it is paramount that we actually make sure that information gets to the individuals that need it. I would say that if you have a community where the kid is living, rural Oklahoma, many hospitals have shuttered. There are fewer community health centers. There are less in-home nursing companies. And even the ones that exist, there are fewer pediatric in-home nurses. Economy, reimbursement, what is more important, who knows? Sure. But I think the idea here is that being able to position ourselves to partner with some providers in the community, or even partner with a, let's say, an advanced practice provider or a physician who would then allow us to share the information with them, be available to them either through virtual visits or remote patient monitoring. A lot of the community health centers that currently exist, or even the hospitals, feel very intimidated by a child that's coming in on a ventilator or on a feeding tube. That is very, very frightening to them. Sure. Having our own hospitalists, having our own providers as resources for them that can support them as they're caring for that kid in that community hospital allows the kid to stay closer at home and is less disruptive to the family. And it also supports professional development with that therapist in the community or with the provider in the community, giving them more knowledge and ability and understanding so that the next kid that comes through the door, they're more capable of caring for the child on their own. Yeah. So I think that would be the other aspect of interoperability, is that we have the information available and we also have ourselves as a resource so that that child can exist in the home, in their community, without the need of having to stay in a hospital for the rest of their life.
Got it. Now that makes a lot of sense. You know, we've especially been hearing about, with the cuts to public health, like you mentioned, a lot of these community hospitals are shuttering. Do you anticipate more virtual care, that only going up, or do you anticipate, you know, there to be lowered health outcomes and more people, you know, coming in to your hospital?
Excellent question. We don't want more patients in our hospital. And I want to make sure I'm clear that if they absolutely need to be in our facility, then that's the ideal. But if it is possible for us to be able to have a system whereby we can triage while the kid is at home, we can have our resources be able to provide that virtual visit. We can do that remote patient monitoring. We're very specific about the equipment that we use within our hospital. It has to be something that can interface with an EHR. And the main reason behind that is because when that kid goes home, we want to be able to have the ability to extract that data, to be able to bring that into a command center, if it were, to, for someone to be able to be alerted to the fact that there's an increase in respiratory rate, or the CO2 that's being exhaled by the kid is increasing, that there are certain kind of triggers that would alert the staff that there needs to be something done. So where I see virtual care going is increasing, particularly in our population, complex pediatric care. I see that as the only way forward for us to continue to provide the same high level of care that they would get within our walls. I would suspect that probably within the next 5 years, a good 40% of our increases are actually going to be virtual. Whether or not the kid ever sees our building isn't important. It's whether or not they have the ability to benefit from the quality of care that they receive from our staff. So I would say that there isn't, in my mind, a crisis, other than we just have to position ourselves in such a way where we can actually meet the need in the community. And I will say that within the NICUs, babies are surviving at younger and younger ages. 23 weeks isn't uncommon. And so those kids generally will end up on a ventilator in our facility. Being able to see them grow, maybe outgrow the ventilator, or to reduce the ventilator settings, end up in our home vent clinic, be able to be at home with family while they're on the ventilator, is something that we need to be able to position ourselves to support. So the kids are surviving at younger ages, and they're surviving with higher need for technology, which means that the need is only going to continue to increase. So whether or not there's those community resources, yes, I suspect to some extent that could create angst, in some groups, but I would like to think that the culture that we operate within our walls, we will continue to operate external to our walls.
It really seems like Bethany Children's has taken those steps to really adopt technology, understand what it can do to improve health outcomes and, equity of healthcare.
Right.
And it's actually putting that into practice, which is really, really awesome to see in healthcare. It's just something that you don't see as often. There's usually so much resistance to adopting new technology. I mean, I understand, all of the reasons for that as well, but it's very cool to see you all on the other side of it and really benefiting from that. In terms of your vision for the kinds of technology that you'd like to see in the future and what that roadmap might look like for Bethany Children's, what might that be?
Well, to look at a little bit of what we're doing right now with our rehab population, these are kids that are coming out of the trauma ICUs or ICUs, brain, spinal cord injury. They'll come into our acute pediatric rehab. And we use a lot of technology to assist in their recovery. There's robotic exoskeletons, whether it's just the arm or just a single lower extremity or the pelvis and lower extremity. There's one in particular that is, it's on, it's kind of like on wheels. So it's got 4 wheels and the kid is strapped in a trunk support and the legs are strapped in an exoskeleton. And so you have a physical therapist that has their tablet there and is programming the therapy, what it is they're supposed to be doing. And so this exoskeleton will take the legs through movements of walking or running, can change the velocity, the gait. And just seeing the expression on these kids' face as they're going from I can't move to I'm, speeding down the hallway is incredible. So that's the type of thing I think that makes the difference. Whatever speeds recovery, whatever accelerates their graduation and their, I would say, their ability to re-engage with their community, wherever that is something that we will most certainly look at implementing. The biggest challenge, I think, right now is having data and knowing what to use it for. And so the advent of AI in that kind of an arena is the notion of being able to utilize a chat functionality that gives complete visibility to the patient's medical record, to the provider that is needing essential information right now.
Immediately, yeah.
Exactly. A good example would be if our neurologist is wanting to know if this patient has been on Tegretol to manage the seizures. Well, if we're going to rely on a parent's recall or the provider's recall, or I'd hate to have to thumb through a medical record, the ability to just create a query against that and say, hey, but not just our current EHR, but, our data warehouse, the Health Information Exchange, national, be able to search against that and to get actionable information. That, I think, will help to accelerate our move towards a greater ownership, I would say, on the part of the parent, family, as well as the clinician, because it's all about a teamwork. And so given that same functionality, I think, to the parent, to be able to search against the patient's portal, against that information to make some sense out of that, would also be an incredible opportunity, I think, for them to become more informed, more educated on their child's condition, and give them, I think, more ability to advocate for their kids. I think that's probably one of the biggest challenges that I think some parents have, is knowing when to advocate for their child's need. And if you can, in fact, empower the parent with the information, you can partner with them in that advocacy.
Yeah. No, that makes so much sense. We at Commure are super excited to be partnering with you guys in terms of your documentation needs and scribing needs. It's our privilege, especially given all the work that you have done and are currently working on. I think these initiatives are extremely exciting. Thank you for sitting with us today.
Well, thank you for having me.